Good afternoon. My name is Angela Polanco, and I'm coming to speak to you today about communicating risk about future fertility with female childhood, teenage, and young adult cancer survivors. My email is just below and my Twitter handle. So if you have any questions or you would like to talk about this topic, get in touch with me after this talk. What I'd first like to do is just give a bit of a background for myself. So I'm a mum of three. I have two beautiful boys, and my beautiful daughter Bethany suffered from Wilms tumour of the kidney when she was 4 years old. Unfortunately, we lost her when she was 8 after a couple of relapses. That was back in 2012. I'm also a registered midwife and have been for 15 years. And the last 5 years of that, I've been working on research trials, so recruiting women and their families into recurrent miscarriage research. Since we lost Bethany, I've also worked quite passionately and predominantly in the parent advocate role for childhood cancer, so making sure that children have a voice within the design of clinical research, making sure that the aims and objectives of research are actually aligned with what children and their families need, and also making sure that the results of research are also shared with people who can actually read it and not just scientific journals. I've been honoured and privileged to be a part of international and national childhood cancer research boards, and I continue to do this alongside all my other roles. When we lost Bethany in 2012, we did set up Bethany's Wish, which was a national Wilms tumour charity. We raised £250,000 and more for Wilms tumour research, and we now sit within CCLG UK as a special named fund. And I'm very proud to be part of that. And it just means that we can continue raising money for research and keep Bethany's name alive. So why did I choose this as a topic? I have a personal vested interest in this. So although Bethany wasn't fortunate enough to survive her cancer, I realised that there is in survival a whole range of problems that children with cancer, young people and young adults all have, and it's important that we concentrate on those as well as the treatment and the cure. My background as a midwife automatically led me to reproductive health and thinking about survivors and how they feel when they want to go on to have families or when they're thinking about getting pregnant. I also thought about the fact that, do they even know that there's specific risks due to their treatment, so their radiotherapy and the chemotherapy. In all my time as a midwife, I haven't seen a specific care plan for cancer survivors. So it got me thinking about, are we telling people about risks that they might have in the future? Or is this something that survivors and families are expected to find out for themselves? And also being within the childhood cancer research arena for such a long time, I have a great appreciation for the fact that late effects are extremely important to families and survivors. People want to make sure that children and young people can live a long and happy life. And things like having a family, having a job, being able to be a normal member of society is really, really important to them. So we need to explore the issues that they might encounter later on in life as well as within treatment. My methodology, I approached this PhD and this research question with an understanding that science is really supported by real life. So although I come from a clinical background and I've studied science quite a lot and believe that data and scientific experiments give us a lot of answers, I don't think that gives us the whole picture. And by including opinions, real life circumstances and talking to people, then that's how you get the full picture, and that's how you can make sure that recommendations and things that come out of the research can actually be applied in real life. I approached it with a critical realism perspective, which is quite unusual within healthcare research, but it's been used more and more over the past 5 to 10 years. And I feel like it's a really good way of demonstrating how science and what happens in real life can be put together and have a really good outcome and analyse all of the details and things that might come into something that we just can't account for by doing an experiment. So I really wanted to find out who should be telling people about the risks, what should they be telling them, why they should be telling them, and also when. These were the key things that I wanted to explore. So my research questions were, what are the communication and information needs of female childhood, adolescent, young adult cancer survivors regarding their risk of future fertility and reproductive health late effects? So in essence, what do young people that have been treated for cancer want to know about their future fertility and their ability to have children? And also, what recommendations can I possibly bring into clinical practice in order to help people feel that they have the answers to their questions, and so that they can go into young adulthood knowing what risks they're at. So my two studies for my PhD were PICS-1 and PICS-2, which stands for Pregnancy Information for Childhood Cancer Survivors. So number one, what I wanted to do is find out what the evidence was out there. And also, what do survivors, parents and professionals think of the theme surrounding future fertility and reproductive health? I also wanted to have a deeper exploration about personal experiences. So PICS-1 was made up of a systematic review, which is where you go out there and find everything you possibly can that's published in a more structured way, but in essence, that's what it is. And then I also did 2 online questionnaires, so one aimed at survivors and parents and one aimed at professionals, asking them their experiences of being told about future fertility and pregnancy risks. And then I also did 8 interviews with professionals, survivors and parents, just explaining to me about their experiences, what they were told and how it made them feel. And then PICS-2 was where I took all of that evidence and that information and thought about where are the gaps and how can I make it better, and what comes next. So this is where we gathered together an expert panel of 19 healthcare professionals, survivors and parents in order to go over the evidence and try and come up with some recommendations for communication of risk that could be taken directly straight into clinical practice and help families and young people. The findings of the systematic review, so in essence, the fishing exercise for all of the published studies, was that late effects information had the highest unmet need, and there was a particular lack of knowledge about fertility status. So in particular, female childhood cancer survivors went into adulthood not really knowing whether they were fertile or not. It was often termed as one of those things that they just had to wait and see what happened. And this ultimately led to high levels of distress, not surprisingly, not knowing whether you might be able to have a child or not in the future, impacted not only the lives of the survivors, but also their family members, their friends, the relationships that they had. We needed to find a better understanding of the barriers to communication. So there was a lack of research out there that examined why aren't we telling people what risks they're at. And there was a lack of consensus around the optimal timing and format for communication. So there was varying instances of when people were told at diagnosis, halfway through treatment, at the end of treatment, and some people weren't even told until they were pregnant. And there was an extreme lack of information about format. So do people prefer written information? Should it be online? So there was a real kind of gap there to explore this in more detail. And also, was there a difference in needs between survivors and parents? It was quite interesting to read some of the papers and just see from the point of view of the survivor whether the parents also had the same level of needs for the same things as their child. The 2 questionnaires that were online, so 48 survivors and parents completed that questionnaire and 29 healthcare professionals completed their questionnaire. Fertility and reproductive health outcomes were found to be important late effects, and healthcare professionals revealed that they had a gap in their knowledge relating to reproductive health risks. So this is primarily kind of pregnancy, having a family later on, and also kind of sexual health and contraception information. There was a real kind of lack of knowledge there about what to tell female survivors. And again, a lack of consensus for the timing when this should happen and who should communicate this information to families was found in both of the questionnaires. So it was quite interesting to see that nobody really knew whose job it was to tell people about these risks. In the interviews, I did 8 of them, and we were able to interview in quite a lot of detail people's experiences and how it made them feel discussing pregnancy and future fertility risks. The findings from the interviews showed that healthcare professionals, that their practices are changing. There is evidence that things are improving, conversations are happening, fertility preservation is something that's kind of standard now, but it's still variable across the UK. It doesn't happen everywhere, and the access to services is still quite different. The key issues coming out of the interviews, as well as the evidence and as well as the online questionnaires, were timing for risk information and also the method and the way that the information is communicated. There was also evidence speaking to survivors and their parents of really deep psychological distress associated with these conversations. So things that were said to them quite a long time ago, they still remembered vividly. And it really did have an effect on them as they were growing up. And it's really important that we kind of look into this and think about how we say things and understand the impact that it might have upon the survivor and their families. Linked into that really was communication needs to be done with compassion, honesty, and in an understandable way. So no jargon, straight talking. Young people really appreciate you just getting down to the facts. But also there's not a one-size-fits-all approach. So it needs to be tailored to each family. There's obviously differences in age and what's appropriate to discuss with the survivors at the right time. So it really needs a healthcare professional to look at the family, look at their needs and see what might be the right time for them, discuss it with them in an open and honest way. So how did PICS1 lead into PICS2? So we had all the evidence and what we were going to do about it. So the key things that came out of PICS1 was timing of information, age of survivor, what should be said, and who should tell the families. So PICS2, it was a modified Delphi consensus technique. So we used 3 rounds of email, and then web-based meeting. It was supposed to be face-to-face, but then COVID happened. So we rapidly had to adapt the design of this. We had an expert panel of 19. So I sent email invitations to 19 people, so healthcare professionals and 5 survivor and parent representatives. And we all came together in order to discuss the issues and the gaps that were found. The whole process was facilitated by a parent representative friend of mine, Neil, who very kindly was involved in the whole of the process of the PhD from beginning to end. And the healthcare professionals represented a wide range of backgrounds. So we had academics, researchers, people from maternity, we had people, pediatric oncologists, we had radiotherapists, we had an endocrinologist. So we had a really wide range of expertise in order to feed into the guidance that we were going to produce about how to communicate risk to this group of patients. The consensus rate was set at 70%, which aligns with CCLG's previous publication to do with Delphi, and also allowed for a bit of room, considering that the topic, there wasn't a lot of research there, and it was quite a new thing that we were looking into. The participation rate of the 3 rounds was 91.2%. We did have an expert panel of 20, but unfortunately due to COVID, one was not able to take part. So the expert panel, we had midwives, we had childhood, adolescent and young adult survivors, we had parents, pediatric oncology, hematology, GPs, nurses, academic researchers and radiotherapists. And at the end of the process, we were able to come up with some expert recommendations for the communication of risk, particularly relating to future fertility and reproductive health. The key recommendations that we were able to put together were that fertility and reproductive health risks need to be discussed. So not just fertility preservation, but fertility risk, fertility status, and whether childbearing or pregnancy might be an issue for that survivor. And it really is dependent upon what treatment they receive and what age they are. But this conversation needs to happen. Risks need to be discussed at diagnosis and throughout the cancer journey. So it should be a process that is ongoing. So things should be brought up at diagnosis, things are important, like fertility preservation, but it should also be discussed with the family throughout the cancer journey and also at the end and into survivorship. It shouldn't be just a kind of tick box exercise where this has been talked about and now we're done. The needs and the questions of the families will change over time. So it's really important to make sure that their needs and their wants are assessed throughout the whole process. Risks should be discussed no later than age 16. So there's quite a lot of conversation around this aspect about what age was appropriate, but the experts decided that 16 should be the age where things should have been discussed, because after that point, really, a young person should be told information that may impact their future life. And at that age, they're able to understand that relationship, but it should be kind of a decision made with the family. The person with the most knowledge and best relationship should communicate the risks. So with regards to the role about who should do the communication of risks, it was often the paediatric oncologist that had these conversations with the parents and the families. But often that might not be the best person to do this. There was evidence to say that nurses and people within the clinic environment or even people outside of the clinic environment might be the best person to discuss risks and issues such as this. Nurses have a very key role and have a very close relationship with families. So we'd advocate that nurses in particular are an untapped resource when exploring communication of risk. Also, find out what being fertile means to the young person and the family. What do they think about childbearing and their choices when they get older? It's really important you have a conversation about what things mean. So what does fertile mean to the young person and the parent? And what do they think they want when they get older? Are they even considering having children, or do they not want to have children? This also extends to kind of sexual relationships, contraception, just figuring out really what are the preferences and what are the choices that that young person wants to make. We can't all assume that everybody wants to have a child when they get older. So we have to be more individualized about our approach and make changes based on those needs. An assessment of needs should be undertaken. So at the point where a young person is starting to think about maybe having a family or getting pregnant, we need to make sure that they have all the information they need in order to make informed choices as they get older. If they are missing a key piece of information, if it hasn't been passed down by their parents or they haven't had the full picture, then it's very hard for them to make choices about their medical care without that key information. So we need to have some sort of assessment at the end of treatment so that we're not missing something. And awareness and knowledge of healthcare professionals needs improving. So there was evidence in the interviews and in the expert panel that healthcare professionals are placing more importance on late effects and having conversations with families, but in particular risks to do with reproductive health. The awareness needs improving, and healthcare professionals need to involve a wider range of disciplines. So people from obstetrics, gynecology, they need to be brought into the conversations, because the young person will be accessing those services and will have questions that they might not be able to answer. And finally, just consider age, maturity, and also conversations with or without the parent. So it might be that a teenager or a young adult might prefer to have these conversations without their parent present. And as healthcare professionals, we should be making sure that we're asking if that's the case and facilitating that, because that might be a barrier to discussing needs and preferences and choices later on. So these are the key things from the guidance that I could put out for you. There's still a lot of unknowns, really. So how can we better support parents and carers to talk about this topic? It's a sensitive topic. It's something that carries a lot of emotion. And in particular, in the interviews, we found that parents and carers often found it difficult to talk with their children about this, and really wanted some guidance from clinicians about how best to do this. So this is still an area that we need to work on. And also, how can we make sure that healthcare professionals from outside paediatric oncology are included in the conversation? So generally we have a multidisciplinary team of paediatric oncologists and people directly involved in the care of the young person. But how do we make sure that people from the adult services, so endocrinology, obstetrics, gynecology, how do we make sure that they're brought in at the right time to make sure that that plan of care meets all of the needs of the young person? And how can we make sure that things are able to change all across the UK? So there's evidence to say that there is change happening in specific centres, but it's definitely not standardised. And how can we make sure that communication of risk is done in the same way everywhere, so that all children, young people and their parents are able to receive the same level of information and support? And one of the big unknowns really is the psychological support for survivors. So there is a lot of evidence and a lot of research that's coming out to do with late effects and psychological impact. So we need to make sure that we are recognising this fact, and also more research is needed about how can we best support survivors and their families to make sure that they don't have psychological distress, anxiety, depression, unmet needs when they become adults. And also, finally, we need more long-term data. So late effects is not just necessarily kind of 10 or 20 years after treatment. It can sometimes be 50, 60 years. So how do we collect this data, and how do we link it back to the childhood cancer treatment in order to make sure that the long-term care of childhood cancer survivors is cared for? So what are the next steps for me? I need to write up my PhD results, and then I'm also going to give a lay summary. So that means that I can write it in a format that people will understand, and share that with charities and organisations and professionals that have helped me to put this together. That will hopefully lead to a publication, and then also explore whether the recommendations can be approved by somebody official, so that we're able to roll that out across the UK. So that is everything. Thank you for listening to me. Thank you very much to everyone that took part in my PhD, that supported me, has been part of the expert panel, has read some of my results, or just provided advice and guidance. And most importantly, thank you to all of the survivors and the parents who took the time out to tell me about their experiences in order to try and make things better. Thank you.